Thanks for joining in, everybody. My name is Harry Hockheiser, Director of the MIDAS Coordination Center. I want to welcome you to our May 2025 webinar. Before we get started, I just want to put in a quick plug for another event that we have coming up next week. Our trainee network is continuing to organize some good programming. And so next Friday at this time, we will have Dr. Anna Bento from Cornell University giving a training network event on how to give an engaging research talk. Uh, so I think this will be a nice event for the trainees, and it sounds like it's going to be nicely interactive. If you can read this here, it sounds like Anna's got some plans to provide real-time feedback during the meeting. So please do join in. We will get that link in the chat once the talk gets started. And then please join if you can. Thank you. So our speaker today is Dr. Greg Cooper. Greg has his medical and his bioinformatics training from Stanford University. He has been faculty at the University of Pittsburgh for more than 30 years now. And I've had the pleasure of having him right down the hall from my office for most of that time, or most of the time that I've been at Pitt, at least, which is the past 15 years. And I found Greg to be a really valued colleague. Greg is known as a leader in Bayesian methods for artificial intelligence, where he's worked in a number of different areas over the years, and having developed some really groundbreaking papers in causal modeling and other topics. I was just looking through here his long and distinguished list of papers on his Google Scholar page and seeing his work going back more than 20 years on Bayesian network anomaly, pattern detection, disease outbreaks, and one of my favorite titled papers of What's Strange About Recent Events, which is also something that work on algorithm for early detection of disease outbreaks. So now Greg is going to tell us about some more recent work that's been I've been played a small part in over the past couple of years on disease outbreak detection. And so, Greg, really appreciate you taking the time to join us today, and we look forward to hearing what you have to tell us.
Okay, thanks, Harry. Thanks for the kind introduction, and I really appreciate the opportunity to speak with you all today. Let me see if I can get my screen share up here, and then we can get started. Does that look okay?
You're great. Go ahead.
Okay, very good. So as Harry mentioned, the topic of my talk today is detection and characterization of outbreaks of novel diseases. And there's a number of reasons why we might care about that, as I'm sure you can imagine. One is that they're not that infrequent. Approximately 40 new human infectious diseases have been discovered in the past 50 years, including SARS, MERS, Ebola, Zika, H1N1, and COVID-19. The risk of new pandemics is really increasing in part due to more travel, denser populations and living conditions, closer human contact with wild animals, and also climate change. And early detection of and characterization of outbreaks of such novel diseases could help healthcare and public health workers in responding effectively to such outbreaks. So identifying the outbreak of such diseases, though, can be pretty challenging. Many of its symptoms may be similar to those of known diseases. It may co-occur during outbreaks of known diseases, and it may affect, at least initially, only a relatively small number of individuals, and we would like to detect it as early as possible, of course. So some strategies for detecting a novel disease include modeling known diseases that could account for the patient cases that are occurring that are not novel, so that we can sort of explain them, but then also looking for symptoms that are atypical, rare, or typically rare in known outbreak diseases, and that also looking for common symptoms that occur at unusual rates currently, looking for outbreaks with unusual epidemiological parameters may be a tip off that there's something novel going on. And also looking at patterns of disease that emerge over time and space may allow us to have enough cases to actually be able to see something that is novel. So our approach to detecting and characterizing the outbreak of novel disease at a very high level, and I'll get into more detail, of course, is to focus on infectious respiratory diseases. And why we're doing that includes that many outbreaks of novel diseases have been contagious respiratory diseases, which typically are viruses caused by viruses. And these diseases are often readily transmissible among humans, and severe respiratory infections can have a high level of morbidity and mortality. We apply natural language processing in our work to full text emergency department reports. And then we use those encoded findings for modeling and detection. And we perform statistical modeling, as you'll see, with that type data. So here's a schematic of, at a high level, of what we're doing. In the training phase, we have many historical ED reports that we process with NLP to get structured data, and then we build clinical models of a number of infectious diseases that are known. In the application phase or stage, we have a current set of ED reports from, for example, today, and we process them with NLP to create structured data. And then we use that structured data for today or for the recent past, along with our clinical models and some algorithms to perform outbreak detection and characterization that I'll go into more detail. So a little bit more information about the characteristics of our approach is that, as I mentioned, we're modeling several common infectious respiratory diseases. And the inference tasks that we've been focused on are detecting first outbreaks of known diseases so that we can account for them and not get confused with them being novel. Another one is detection, of course, of the outbreak of a novel disease itself in light of perhaps known diseases. Also, clinical characterization of the novel disease in terms of its findings and their probability distribution, frequency. And then finally, identify patients who are most likely to have the novel disease. And this could be helpful in terms of public health or clinical follow-up on those patients if there's a suspicion that there is a novel disease in the population. And our methodological approach at a very high level is this. If models of known disease do not predict current ED data well, it suggests the possibility of the presence of a novel disease. So the outline of the remainder of my talk is shown here. I'm going to give some brief background, and I know that it's just a sketch of the tremendous amount of work that's been done in the area of disease detection and surveillance and related methods, but I'll try to give some representative work. And then I'll talk about the approaches that we've pursued. One is a body of completed research, which is a hybrid Bayesian or really likelihood-based and frequentist approach, and we call that ILI tracker. I'll first talk about the method and then some experimental results. And then secondly, I'll talk about ongoing and sketch the ongoing research of a fully Bayesian approach. First, just talk about the general methods that we've been pursuing, and then some preliminary results, and then I'll end with conclusions. So in terms of some representative related work, there's been a lot of work, as I mentioned, on disease surveillance, and there's some of the ways that have been used for that, as you all know, are laboratory testing of infectious pathogens, sentinel physicians, syndromic surveillance that I'll return to, and other methods that use different patterns of information or data in the population, such as absenteeism from work, looking at changes in traffic patterns, looking at social media data, and looking at, for example, over-the-counter pharmacy sales. In terms of syndromic surveillance, and there's a good review article here that I reference at the bottom by Jan and also David Buckridge and others, but it often uses outpatient or ED chief complaints as the data. and it commonly runs continuously and automatically using electronically available data, and it typically is applied to detect known diseases. There's also been interesting work done in detecting outbreaks of novel diseases, and I'm just going to give a few examples here. This is some work by Lee and colleagues on analyzing chief complaints and triage notes to identify clusters of similar patients who've recently come to the emergency department. Another body of piece of work is by Howard Burkham and colleagues on analyzing chief complaints within a current 8-hour ED window to identify words that are unusual statistically relative to a previous baseline period. Some work by Nobles et al. Is using latent Dirichlet allocation and spatial scan statistics to identify emerging topics in recent ED chief complaints. And then some very recent work by Howe and colleagues is on using a large language model to analyze electronic health record data in order to try to detect a novel disease. So some of the features that distinguish what we're doing, I believe, are shown here. It uses a large set of clinical findings that are extracted from emergency department reports as opposed to chief complaints, for example. It explicitly models the clinical presentation of a set of known infectious respiratory diseases, including influenza and RSV. It can characterize or estimate the clinical features of the novel disease, if in fact there looks to be one currently, and it can predict the individual patient cases that are most likely to have a novel disease. So now I want to go into more detail about a method that we have developed and evaluated called ILI tracker. And there's a reference at the bottom of this slide to a paper from last year in JMIR Public Health and Surveillance that goes into more detail about all that I'm going to be presenting here. But the basic idea is if only known diseases are present, then models of known diseases should explain the data well. Otherwise, they will not explain the data well. So ILI tracker models several diseases that commonly cause infectious respiratory disease, and I'll talk about those in a minute more. And it also models what we call a catch-all set of other diseases, which is basically everything else, such as appendicitis, such as COPD, all those many things that can happen besides the infectious diseases that we explicitly model, respiratory diseases, we put into this catch-all model to try to account for them. And it uses those models to monitor on a daily basis the findings that occur in the emergency department reports of patients who are visiting the ED. And if those models don't explain the data on some day well, ILI tracker will identify the data as being unusual. So going a little bit deeper into the data that we use that I'm going to be presenting today, some results for, comes from 5 University of Pittsburgh Medical Center emergency departments in Allegheny County from June 1st, 2010 to May 31st, 2015. And the data itself consists of free text ED reports that were mapped to 79 clinical findings that earlier in the project, some of our clinical experts deemed to be relevant to ILI or influenza-like illness detection. And we used the Topaz NLP software to do that NLP mapping, and a reference to that software is at the bottom of the slide. We used the data from June 2010 to May 2014 for training, and then the data from June 2014 to May 2015 for testing. The models that we used, we looked at laboratory positive cases during the training period, and we used those cases to model these four respiratory infectious diseases: influenza, RSV, HMPV, and parainfluenza. And then the catch-all diagnosis, which I'll call just other, was constructed from training cases during the training period in the months of August, where there's typically not many of the above respiratory diseases that are active, at least not in Allegheny County. And also we required that those cases, none of those cases be tested for any of the above diseases, such as PCR testing. And for each of these 5 diagnoses, we applied the K2 Bayesian network learning algorithm to the training data to construct Bayesian networks for each of the 5. So we constructed a model that predicts the findings given the individual disease, such as influenza. And the AUCs of these models, when we applied them to the test data, were in the range of 88% to 92%, which is pretty good. So here's an example of the 20 most informative findings in the Bayesian network for RSV. And you can see that RSV is a binary node that's kind of in the middle here, but we also have as a finding, we'll have a probability of bronchiolitis given RSV, a probability of respiratory distress given RSV, a probability of chest wall retractions given RSV. So all of these findings were found by the Bayesian network learning algorithm to be relevant. And the relationships among them were also modeled. So we get kind of a joint probability distribution of the findings given RSV or not RSV. And we had one of these models for each of the 5 diagnoses. So in terms of the algorithm that we use, the basic approach, we use Bayesian filtering method that operates in the following way. The posterior probabilities from yesterday relative to today, the current day, for each disease I were used as prior probabilities of that disease today. And for each ED patient J seen today, we use Bayes' theorem to derive the posterior probability of that disease, given the findings of that patient case, by using the disease prior that I just mentioned, and using the Bayesian model-derived likelihood of the probability of the findings in that case, given disease I. And then, once we've got the posterior probability for each disease, given the findings of each case, so essentially we can do a probabilistic diagnosis for each patient case that came in the ED today. And let's suppose there's N cases that came into the ED today, or the EDs, really it's the union of across 5 EDs. We derive the expected fraction of them for each disease I as follows. We sum the probability of disease I over the J patients that were seen today. And then we divide that by N, the number of patients seen today, to get the fraction of patients that we estimate have disease I who came to the ED today. And we use that as an estimate for the posterior for disease I. So again, the expected fraction of disease I today is used as the posterior of that disease for today. And we plot the time series of predicted disease posteriors for each day in the recent past up to the current day to give some idea of the system's estimates of, what are the likelihood of the presence of those diseases over time. And so then the disease posteriors for the 5 diseases for today become the disease priors for those diseases for tomorrow in a Bayesian filtering fashion. And now, with that as background, I'll talk about some experimental work that we did with ILAD Tracker. We applied it to test data from June 1st, 2014 to May 31st, 2015 to derive a time series of the predicted number of each model disease on each day. And then we evaluated how well that correlates those predictions of the diseases over time to the actual laboratory confirmed number of cases of each disease. Of course, not everybody is tested, but for those that are tested, we're looking at them as being the gold standard for at least in terms of a pattern, a qualitative pattern. What's the nature of the number of cases for each disease in the population or in our ED population? And we also evaluated how well ILI tracker predicted the peak day of the laboratory positive cases for each day. So here are the results, and the blue shows the predictions of ILI tracker in terms of the expected number of cases, which is proportional to the posterior probability. And then the red is the laboratory confirmed cases in our test data, and we used a 7-day moving average to produce these results. So if you look at the top here, this is for influenza, and you can see in the red that's what were the PCR number of cases here for influenza that were tested, and ILI tracker is doing pretty well in terms of tracking along, not perfect, but doing a decent job of tracking influenza or predicting influenza from the clinical findings. For RSV, it's interesting. Over here at the right, you see that it's pretty good correspondence between the laboratory tested cases and the estimates from ILI tracker. But over here on the left, it's quite out of kilter with respect to each other. And I'm going to return to that because it turns out that we think it's likely that there was a novel outbreak there. And we'll see how well ILI tracker did in terms of finding that or raising that as a possibility. Here's HMPV, and the tracking there is reasonable. And here's parainfluenza, and the tracking there also looks to be fairly decent. And so if we look at the correlation between the red and the blue in the previous slide, we get a strong correlation, Pearson correlation for influenza of about 81.81. For RSV, it's and HMPV, it's strong, I would say, 0.66 and 0.72 respectively. And then parainfluenza, I would say it's moderate in terms of the correlation, Pearson correlation of about 0.51. We also looked, as I mentioned, at the peak a day prediction from ILI tracker being able to predict the peak day that occurred on the laboratory confirmed cases. And for influenza, it was 6 days off. For RSV, it was 6 days off. The peaks were for HMPV, it actually was right on the mark. And for parainfluenza, it was 4 days off between the two peaks. Now I'm going to switch from talking about how ILI tracker can be used to try to estimate or nowcast what's going on with a set of respiratory diseases that it's modeling to how it tries to detect a novel disease. And so this is sort of a foundational piece of what we do. We derive the likelihood of the patient data for each day using this equation. And so this equation is basically deriving the probability of the findings for each patient case, and from that, deriving the probability of the findings for all the patient cases on a given day. And that becomes the likelihood of the patient data, essentially given that we're modeling a set of known diseases. I leave out the conditioning part here, but I'll bring it back in actually in a little bit. And we derive a p-value for the probability of the patient data on the current day by comparing it to the probability of that patient data on previous days in the recent past. So in terms of experiments, we applied ILI tracker to derive a p-value of the patient data for each day during the test period from June 1st, 2014 to May 31st, 2015. And this shows the results that we got for the daily p-values over that period. And you can see that there was basically 3 episodes, if you will, where it found low p-values. This one here in starting in August of 2014. This one starting in November of 2014, and this one just a single day in May of 2015. So related events that were going on in the August, if we look at the August first episode, was on August 19th, the CDC was notified of an increase in pediatric patient cases with severe respiratory distress in Kansas City, Missouri. Then on August 23rd, the CDC was notified of similar increase in pediatric patients in Chicago. And then in late August and early September, the ED at UPMC, a children's hospital in Pittsburgh, had an increase in children presenting with acute respiratory distress, and a number of those cases also had dyspnea. On September the 8th, the CDC reported that nasopharyngeal specimens of the large majority of the patients from Kansas City and Chicago tested positive, that they were sending specimens for, tested positive for enterovirus D68, which I'll sometimes just abbreviate as EVD68. And then in September 16th, there was public health disclosure that 4 pediatric patients in Philadelphia had tested positive for EVD68 as well. So on looking at what ILI tracker found, on August 25th, according to it, 8 of the 10 patients with the lowest probability of their findings showed evidence of respiratory illness. And then starting on September the 2nd, which is over here, there were 4 days, and you can see these 4 peaks here, within 1 week with highly unusual patient findings, for which the most unusual patients during those days had respiratory disease. So it seems likely that the novel disease detected by ILI tracker starting on August 25th was EVD68. Relatedly, for each day being monitored and for each finding, we computed the expected number of cases with that finding and subtracted from it the expected number of cases for that finding during an earlier training period in order to derive what we call just the excess of cases of the finding, excess that is currently relative to a baseline background training period. And this shows the daily counts for the top 10 excess findings during the week starting September the 2nd. It uses that to find these 10, but then it plots them over the whole year. And what we can see here, well, we see that, for example, the green here is cough. Wheezing is blue, which is kind of in the middle. The light blue here are chest wall retractions, which has an increase here, but not as dramatic as some of the others. And you can see some of the sore throat, tachypnea, respiratory distress, and so forth are among the other 10. Common symptoms of EVD68 itself include, in general, wheezing, cough, rhinorrhea, nasal congestion, and dyspnea. So these symptoms that are known to occur with EVD68 and their temporal patterns over the outbreak period are consistent with these 10 excess findings that are shown above. If we look at some of these other periods, these other 2 periods, then November the 24th, the most unusual patients during that episode showed signs of respiratory illness. But the nature of this episode remains an open question. We were not able to resolve, what that was. And then on May the 13th, we believe and we interpret that this is most likely an isolated day in which unusual findings occurred. And using a frequentist method, you would expect occasionally that would happen. We also copied many of the most unusual respiratory cases from that September 2014 EVD68 period. We copied them and inserted them into existing cases in March of 2015 when there happened to be a significant increase in cases of RSV and HMPV. And we wanted to test if ILI tracker would be able to detect those inserted cases as being highly unusual, even in this challenging situation where there were other types of known diseases that were happening with high frequency. So what you can see here at the top is something that you've seen in part before. This is for RSV, and you can see that here in the March period, there were quite a number of cases according to at least the PCR testing. And for HMPV, even though at a lower level, absolutely relative to RSV, there still looked to be something going on here in terms of increased cases during the March 2015 period. So what we did is we took cases here from the August, September period, and in September actually, and we transported them and inserted them over here in the March, starting on March the 1st, 2015, and inserted them into March. And you can see here that ILI tracker is not really indicating that there's anything highly unusual going on during this period in terms of a possible novel disease. But we wanted to see if we put those cases over there, if it would notice this, have a signal. And it did. These black bars show where we took the cases from, and then this black bar to the right shows where we inserted them. And so we inserted them starting on March the 1st, and on March the 2nd, it detected that there was something highly unusual going on. And by that point, there had been about 150 cases inserted. And it looked unusual for the remainder, for much of the remainder, for several times in the remainder of the month. So that covers ILI tracker and some of the work that we've done in the past. I wanted to talk now and switch gears and talk about some of the ongoing research. What we have been focused on doing and trying to do is to develop a fully Bayesian approach for detecting and characterizing an outbreak of a novel disease. And some of the advantages of a Bayesian approach include that it can incorporate prior knowledge or information readily and easily. It can derive the posterior probability of there being a novel outbreak, and those posterior probabilities could be used in analytic decision making. It facilitates incorporating multimodal data, given that it's a generative model, or at least it sometimes can. And ultimately, it may work well for the above reasons. So we model novel disease within this Bayesian framework as one which we are flexible or uncertain regarding how it may present clinically. And then we try to use Bayesian learning to have that very flexible model fit the data for the novel cases, so that that fit plus the known diseases will account for the data that's being seen in the ED much better than just modeling the known diseases. So this is our equation that I've shown before for modeling the likelihood of patient data given known diseases, or as I'll say here, not novel, so known diseases. And in order to model here the likelihood of patient data given novel, conceptually what we do here is introduce another disease, the probability of the findings for a given patient case given the novel disease times the prior probability of the novel disease. So this really becomes like a sixth disease or diagnosis to augment these five that we already had. It's a little bit, as you likely will know, it's a bit more complicated than that because we don't know the parameters, which I call theta, which are the probabilities of the findings given this novel disease. That's what we'd like to learn. And so we need a prior from a Bayesian approach, we need a prior probability of those parameters given that it's a novel disease. And then we need to integrate, or ideally integrate over those parameters in order to derive this likelihood given novel. But if we're able to do that successfully, we can apply Bayes' theorem, where we have these likelihoods for patient data given no novel and patient data given novel. And then we have a prior probability for novel or no novel on the right side here. And from that, we can derive the probability, posterior probability of novel given the patient data. So that's what we've been striving to do at a high level. The challenge is in solving that integral and making some of these estimates. So we did look into that approximation somewhat, but we also have looked at efficient approximations, which I'll talk about more here. What we do is we update the parameters defining the novel disease, that is that theta, in a sequential daily manner that's analogous to how we use the disease posteriors from yesterday as the disease priors for today. So in a Bayesian filtering sort of way, we also update these parameters theta. And so I just notate that here as theta hat, where on each day we're going to update theta hat, which are these probabilities. And we basically start with a Dirichlet distribution that's very non-informative, and we update it to become more informative about the parameters on a day-by-day basis. The advantages of this approach are that it's fast, efficient, and it worked well for some simple outbreak scenarios that we initially tried. So I want to dive into that for a moment, and then I'll come back to some disadvantages. This is an example of the approximation for this simple outbreak scenario that we tried. And the method was that we only modeled the catch-all diagnosis other in this experiment. And in particular, we did not model influenza, but we applied the method during a period of time in 2019 when there was an influenza outbreak. And we wanted to see if other being the only known disease, if you will, and then introducing the possibility of novel, if it would find that novel had a posterior given the data that was much higher than just very, very high during this period of outbreak. So more specifically, what we did, though, was we used the sequential Bayesian method to estimate the number of novel cases on each day, which is related to the posterior. And you can see that starting here back in July, it increased to a peak and then started decreasing. So those were the estimates for novel disease count over that period. And then the goal shows the PCR positive cases for influenza during this period when there was an outbreak of, you might remember back in 2009, of H1N1, including, such an outbreak in Allegheny County. So early in the outbreak, around September the 8th, which is about right here where my pointer is, the novel disease model contained the following three most frequent findings. Fever at 73% probability of occurring in a patient case, novel patient case. Cough, 64%, and acute onset, 57%, which are all consistent with influenza. So we viewed that, of course, this is a limited experiment, and it was a big outbreak. So in some sense, it was easy, but we were encouraged by this and continued to pursue it. But some of the disadvantages that we encountered with this method was it has not worked well for more complex, realistic outbreak scenarios where we have a lot of things going on. And one of the reasons why that is the case is that the method learns a novel disease model that overfits the patient cases that often are not novel diseases. So it becomes a bit of a black hole in terms of absorbing more than it should of the cases and explaining them. And we have tried numerous variations based on insights that we've gotten from this sort of overfitting to try to address it. But so far, we have not found a really good solution. But we keep trying. In the meantime, what we've been exploring is a variation on that, another estimation technique, which is to rank patient cases in terms of how unusual they are, and then use the most unusual cases to learn the parameters theta hat for a novel disease model. And then essentially plug that novel disease model into this equation here as a sixth model disease, and see if that explains the patient data better in a Bayesian fashion when it's plugged into Bayes' theorem, better than does not modeling the novel disease. And we've also expanded the set of clinical findings to be UMLS concept unique identifiers that contain over 20,000 concepts. So our vocabulary for basically being able to represent the clinical findings of a case have become much richer. The preliminary results, and I emphasize they are very preliminary, to date are promising. The method was able to detect a novel outbreak, and I put that in quotes, due to COVID-19 patient cases that were injected into a non-outbreak period. Again, it's early exploration. This approach is quite early, and a lot more needs to be done in developing and evaluating it, but it looks to be promising. So now let me end by summarizing and giving some conclusions. We found that early detection of a novel outbreak disease was possible by modeling several known diseases and observing when they did not predict the patient data very well. And this approach could leverage ongoing advances in modeling known infectious diseases, such as the work that you all are doing in the MIDAS project, and incorporating many more diseases, many more disease models may well improve the detection performance. Essentially taking out diseases that are being modeled rather generically in this other category and making them their own disease. As I mentioned, developing a fully Bayesian approach we found to be challenging, and efficiently and effectively identifying unusual patient cases and building a novel disease from them looks to be promising as an approach to help meet the challenge of a fully Bayesian approach. Of course, much more needs to be done in evaluating these methods and comparing them to other approaches for detecting novel disease outbreaks from clinical and other types of data. We remain optimistic. We think that there remains significant opportunities for developing better methods for the detection and characterization of outbreaks of novel diseases. And if highly effective methods can be developed and shared around the world, it opens up the opportunity that these methods may be able to help detect novel diseases and therefore help contain them as early as possible. So I want to acknowledge my colleagues at the University of Pittsburgh and the RODS Lab for many significant contributions in development, implementation, and evaluation of the ideas that I presented. They include especially John Aronis, who's put a lot of time and effort and to the research that I presented here, as well as others, Jesse Espino, Harry Hockeiser, Marion Michaels. And I also, Mike Wagner and Rich Twee made substantial contributions to earlier research on which the research that I presented today is based. Also want to thank John for helping create the slides in this presentation. And of course, acknowledge and thank the NIH for the funding that they've provided for this project. And I give some details here about the particular grants that help fund this work. So thank you for your attention. And we have some time, I believe, now, and I'd be happy to hear your comments or suggestions and try to answer any questions that you have. Thank you.
Great, thank you, Greg. Very nice talk. We've already got a couple of questions in the chat, in the Q&A, I should say. Anybody who has further questions, please feel free to put them in the Q&A or to or the chat, either way, and we'll get to you as we can. Jacob, would you be willing to ask your question live?
Hello?
Yes, Jacob, go ahead. Yes.
Oh, okay, you can hear me. Perfect. So I actually have two questions. Maybe perhaps I'll start with the second one. How do you define a novel disease? Because each time I go to the doctor, they give me a flu shot and say, oh, it doesn't work on the flu this year because the flu this year is new. So there's always like the flu is constantly changing. So how do you define specifically that you have found something novel? Like what's the granularity of this?
Yeah, well, I mean, sort of mathematically, the equations that I showed operationalize, what we mean by it, but there is no, it's a sliding scale, if you will, because, different diseases can be relatively more or less novel, or have p-values that are relatively less or more close to zero, depending on the model, the known diseases that you're modeling. So it depends on a lot of details about how we're within that framework, such as how precise are we modeling the known diseases? How many known diseases are we modeling, and so forth. So you're right. It is not a deterministic concept where it's binary and it's either novel or not novel. It's on a bit of a sliding scale. And so what we're trying to do is reflect that scale and have the, ultimately the public health or clinicians who are using such methods as gauges of what's going on in the population, have them interpret whether or not the extent of the novelness is significant for them to act on it. And that may depend on having some experience with a given system over time and calibrating what the level of novelness needs to be in order for it to be acted on in different ways.
Okay, so I got it. It's like it's something that needs to be determined in a sense if you ever want to do it more specific. But I get it. Even those new machines, the new AI also doesn't really allow some quantification. Let's go. I'll ask you something different. It's like about the approach at all. So what you're doing is something very similar, at least to my eyes. Maybe I'm wrong. To what was doing like a big thing. I know about 15 years ago, something like this, give or take 5 years. Something called Google Flu Trends. They were looking at keywords and saying, "Oh, this is how well we can predict what's happening now with flu or whatever." So, how far are you from that? And are you like Google Flu Trends no longer works? You cannot even find it, or at least a few years ago you couldn't. Maybe someone resurrected it. But how are you trying to go in the same direction? It's like I know it's research, but are you trying to establish a mechanism that will replace it with newer tools, or do you have something like this in mind?
I think Google Flu Trends is similar to some of the methods that I reviewed as related work, representative related work, where they were looking at the novelty of the terms that were occurring over time in the current time relative to a previous time. What we're doing is that's somewhat different, is that we are modeling known diseases at some level of fidelity. And we're using that in order to contrast or determine if the current data can be explained well by the known diseases. Google Flu Trends was not modeling known diseases and using such an approach.
So you're expanding on it. You're basically saying, okay, we're not doing only flu, we're doing some other things as well.
Yeah, we're modeling other diseases, and we're modeling the clinical presentation of those diseases. Yeah, more expansively, I guess you could say. And we have been exploring different approaches, given that we're modeling diseases. I've presented two of them, ILI tracker and this other kind of fully Bayesian approach. We've been exploring different ways of using that the modeling of known diseases to try to detect novel diseases. So I think some of the algorithms that we've been exploring to try to do that are different than Google flu trends as well.
So I got it from what you're doing, but now this is the level of research. Are you trying to, like Google Flu Trends, there was a website. You could actually go there and see what's going on, and this was kept up for a long time. Are you trying to create a mechanism like this? I know maybe a company that will hold this mechanism or something that like in the future will have, or are you just leaving it at the level of research and someone else should pick it up?
Well, we do have our, like ILI tracker, we do have, the code itself available on GitHub for anyone to use or to modify. And so our goal is to try to make, the research goal, of course, is to try to make it as good as we can in terms of detecting novel diseases quickly and accurately. But we really would like to, make these available to everyone for free and as open source.
Okay, so we'll talk later because this is not part of the webinar, but this is interesting. Thank you.
Yeah, thank you.
Okay, we have another question here from David Guerrari, short one, so I'll just read it myself. Do you use any molecular genetic data in identifying novel pathogens?
We have not. We've been focusing on clinical, but there certainly is other kinds of data like that that could be helpful, and becoming increasingly so. We have been exploring some use of over-the-counter, which is a different. It's multimodal, but it's certainly different than molecular. But we've been looking at over-the-counter pharmacy cells in the population and looking at the possibility of combining that with ED data. So there's a lot of I think opportunities to combine data across different measurement modalities in society, such as the different kinds of social media platforms and ED data, but also within any given environment like the ED, looking at additional types of data like molecular data. We've mainly used the molecular data as defining gold standards, but there's a lot of opportunities to use it increasingly, I think, as you're pointing out, for doing detection itself.
And Greg, if I might jump in there in a second, it seems like one of the things that would be really low-hanging fruit might be to go beyond ED data to other forms of notes. For example, primary care might give some interesting additional signals that you wouldn't see in ED notes.
Yeah. And we have looked at some laboratory findings that are available. Of course, labs are ordered in the ED and you can get, structured results back. So we have looked at some things like that, some laboratory results, not specifically, sort of advanced molecular data, but more like traditional labs. And so that is another opportunity to sort of expand the richness of the disease models.
Great, thank you. Any additional questions? We've got a couple minutes here. If anybody's got anything else to ask. It's hard for me to come up with questions here since I'm so familiar with the work. But
So I have a question.
yes, go ahead, Jacob.
Okay, so I know you want to detect new things that are happening out, but how can you incorporate them with other things that you do know? Like, do you have like interfaces to other systems, or is it just a standalone solution for something?
I mean, we haven't really developed those. I mean, in the case of the over-the-counter pharmacy sales, we do have that we have been doing some work over a long number of years on that, and so we have more ready access to that kind of data, and we have explored using that kind of data along with the ED data, but it's been very on the research end of things and not sort of on the deployment end of things. So we really haven't developed tools that allow us to incorporate, other kinds of data within the types of systems that I've talked about, like ILI tracker, easily. So that's still to be done. Does that answer your question though, Jacob?
Somewhat. I'm exploring some sort of. I'm trying to understand where how does you obtain your data, because it's like you mentioned, oh, you have pharmacy, you have perhaps, I don't know, access to pharmacy sales, or perhaps it's public, I don't know, but how do you get your data, and if other connections to other types of data may help you, or like integrations with other systems that you can give a voice about, oh, we think there's something new going on here, and then cross-reference it with other systems. I'm biased here with my question.
Okay. Well, I mean, I just could say that we really have not explored that very much. We've been focused on the ED data. We know that needs to be, there's real opportunities for expanding that. But we've had our hands full, honestly, with just trying to model with the ED data, and it's also been very rich set of data. So that's something that we needs to be, from our point of view, explored more.
Okay, good answer. Thank you.
Thank you.
With that, I think we're about out of time. So I'd like to say thanks once again, Greg, for the nice talk. Really appreciate you taking the time to spend with us. Thanks everybody for coming. We will see you all at the June MIDAS webinar next month.